Welcome to Evidence-Based Cardiology Talks, where we really unpack the latest, most relevant publications in contemporary cardiology for you.
Great to be here.
Today, we're really getting into some significant long-term data.
Yes, the 5-year outcomes from the Evolut Low Risk trial.
Yeah.
Really important stuff.
Exactly. It's just published in the Journal of the American College of Cardiology. And we want to unpack what this really means for treating severe aortic stenosis, specifically in those patients at low surgical risk.
It's a crucial study. I mean, TAVR, transcatheter aortic valve replacement, it's become so common now, even in lower risk groups.
Right.
So understanding how it holds up, its durability over the longer haul, 5 years out, that's absolutely key.
Couldn't agree more. So the big question is, what are these 5-year results actually telling us? How does TAVR really compare to traditional open heart surgery, with a bioprosthetic valve in these low-risk folks?
We've seen the shorter-term data look pretty good.
Yeah, promising. But 5 years, that gives a much clearer view, doesn't it? Potential pros and cons.
Absolutely. And this trial, it was a head-to-head comparison. Patients were randomized, either getting TAVR with a self-expanding valve.
That's the Medtronic core valve family, right? Evolut R, Evolut PRO.
Exactly those. Or they got standard surgical aortic valve replacement with a bioprosthetic valve.
And the original main goal, the primary endpoint, that was looking at 2 years.
That's right. A combo of all-cause death or disabling stroke at 2 years. But now, crucially, we have this 5-year follow-up. That's our focus today.
Okay, let's jump right in then. The primary endpoint outcomes at 5 years. What were the headline results?
Well, this is maybe the biggest takeaway. The rates for that primary endpoint were remarkably similar between TAVR and surgery after 5 years.
Really? How similar?
So the Kaplan-Meier estimate for that composite death from any cause or a disabling stroke, it came out at 15.5% for TAVR.
Okay.
And 16.4% for surgery.
Yeah, that is close.
It really is.
Yeah.
The p-value was 0.47. So, statistically speaking.
No significant difference. It could easily be chance.
Precisely. The main outcome, basically the same at 5 years.
Okay, that's a huge finding. Let's break that down a bit more. What about just looking at death from any cause, all-cause mortality?
Again, very, very similar numbers. All-cause mortality was 13.5% in the TAVR group.
And surgery?
14.9%. The p-value there, 0.39. So again, no statistically significant difference.
And disabling stroke on its own?
Also very close. 3.6% for TAVR patients and 4.0% for surgery patients. P-value is 0.57.
So looking at the big hitters' death, disabling stroke, TAVR, and surgery look neck and neck at 5 years in this low-risk group.
That's the picture emerging, yes.
Yeah.
They also looked at why patients died, cardiovascular versus non-cardiovascular causes.
Ah, interesting. What did that show?
Well, cardiovascular mortality was 7.2% with TAVR and 9.3% with surgery. P-value 0.15.
So a slight trend favoring TAVR there, but not statistically significant.
Exactly. Didn't quite cross that threshold. And non-cardiovascular deaths were almost identical, 6.8% in TAVR, 6.2% in surgery, p-value 0.73.
So pretty much the same risk of dying from non-heart-related causes.
Correct. And they did something else important, too. They did a sort of sweep, checking the vital status at the hospital sites for patients lost to follow-up.
Oh, good. To make sure missing data wasn't skewing things.
Precisely. And even with that check, the all-cause mortality rates stayed super close, 14.7% for TAVR, 15.2% for surgery. P-value 0.74.
Okay, that really strengthens the finding that overall mortality is similar. So the big picture endpoints look comparable. Let's move to some secondary clinical outcomes. What about heart attacks, myocardial infarction? Was there a difference there?
There was a bit of a signal there. At 5 years, MI rate was 6.0% in the TAVR group versus 3.6% in the surgery group.
Okay, so higher with TAVR.
Numerically higher, yes. The p-value was 0.06, so it's suggestive of a possible trend, maybe a slightly higher risk with TAVR.
But not quite statistically significant at this point.
Right, it just missed that 0.05 cutoff. Definitely something to keep an eye on in longer follow-up, though.
Absolutely. Now, atrial fibrillation, AFib, we often see big differences there post-procedure.
And we certainly did here. This was a major difference. At 5 years, only 16.3% of TAVR patients developed new AFib.
Only 16.3%. Okay, and surgery.
A whopping 41.2%.
Wow.
Yeah, the p-value was less than 0.001. Highly significant. A clear win for TAVR in reducing that risk of new AFib.
That's a huge practical difference for patients. Rhythm issues, anticoagulation potentially.
Absolutely. It impacts quality of life, medications, stroke risk down the line.
Okay, but on the flip side, what about pacemakers? TAVR often comes with a higher rate there.
That's the other side of the coin, you're right. For patients who didn't already have a pacemaker,
Yeah.
the rate of needing a new permanent pacemaker was significantly higher after TAVR. It was 27.0%.
27% compared to surgery.
Only 11.3% in the surgery group. Again, highly significant, but less than 0.001.
So that's a definite trade-off to discuss with patients. Nearly 1 in 4 TAVR patients needing a pacemaker they didn't need before.
It's a well-known factor, particularly with these self-expanding valves. It's part of the shared decision-making process.
Definitely. Okay, what about the valves themselves? Issues like valve thrombosis, clots on the valve, or needing another procedure or reintervention. How did they hold up?
This was actually quite reassuring. Rates of valve thrombosis, both clinical, meaning it caused symptoms, and subclinical, just seen on imaging,
Yeah.
they were really low in both groups at 5 years. Clinical thrombosis was tiny, like 0.3% TAVR, 0.2% surgery. Subclinical was 0.6% versus 0.5%. No real difference.
Okay, that's good news. And needing a valve redo.
Also very similar. Valve reintervention rates were 3.3% for TAVR and 2.5% for surgery. Again, no statistical difference. P-value 0.44.
So despite being different types of valves placed differently, both seem pretty durable through 5 years in terms of those major valve-specific problems.
That's a fair summary, yes.
Yeah.
Good durability observed so far for both approaches regarding thrombosis and reintervention.
Great. Let's shift gears slightly to the echo findings, the ultrasound pictures of the heart valves at 5 years. How did they look functionally?
This is where we see some interesting hemodynamic differences. The TAVR valves generally performed better in terms of blood flow.
How so?
Well, the mean aortic valve gradient, that pressure difference across the valve, was significantly lower after TAVR. It was 10.7 millimeters of mercury,
Compared to
12.8 for surgery. And the effective orifice area, basically how wide the valve opens.
bigger is better, generally.
Right. It was significantly larger with TAVR, 2.1 square centimeters versus 1.9 for surgery. Both these differences were highly significant, p less than 0.001.
So the TAVR valves were, on average, opening wider with less resistance at 5 years. That sounds potentially advantageous long-term.
It suggests better hemodynamics, yes.
Yeah.
Which could theoretically translate into benefits later on, though we didn't see a survival difference yet.
Okay. But what about the leakiness around the valve paravalvular regurgitation, PVL?
Yeah.
That's often more of a concern with TAVR, isn't it?
It is, and the data reflected that. Mild or greater PVL was definitely more common. After TAVR, 14.7% of patients had it.
Compared to surgery.
Almost none, 0.5%. Highly statistically significant difference there.
Okay, so more leaky valves with TAVR. Is that a major problem then?
Well, here's the important nuance. A lot of the mild PVL seen early after TAVR actually got better over time.
Oh, interesting. It resolved.
Some of it, yes. And maybe even more importantly, when they looked at survival at 5 years.
Yeah.
TVR patients who had mild PVL at 30 days had similar mortality rates to those who had no LIS or just trace PVL.
Ah, so even though mild leaks were more common in this low-risk group, it didn't seem to negatively impact their 5-year survival.
Exactly. That's a really key finding. Moderate or severe PVL is definitely bad, but the more common mild PVL didn't carry that same ominous prognosis here.
That's really helpful context. Okay, last major area. How did patients actually feel? Quality of life at 5 years.
This was another area where both groups did very well. And very similarly, they used the KCCQ score, the Kansas City Cardiomyopathy Questionnaire.
It's a standard measure for heart failure quality of life.
Right. And the scores at 5 years were high and almost identical. 88.3 for TAVR, 88.5 for surgery. No difference.
So patients felt equally well, regardless of the procedure.
That's what the scores suggest.
Yeah.
And most patients in both groups were asymptomatic NYHA class at 5 years.
Great.
And they also looked at the proportion who were alive and well, defined as having a KCCQ score over 75. That was also similar, around 70% in both groups.
So summing up the patient experience, it seems like both TAVR and surgery led to significant, sustained improvements in quality of life out to 5 years for these low-risk patients.
That's a very fair conclusion, yes.
Yeah.
Similar high quality of life reported in both arms.
Okay, so let's try and pull this all together. The big conclusion from this 5-year Evolut Low Risk data seems to be what?
I think the main message is that for low-risk patients with severe aortic stenosis, TAVR, using these self-expanding valves, shows comparable results to surgery at 5 years when looking at the really hard endpoints, all-cause death and disabling stroke.
Comparable mortality and stroke.
Yes. And we're seeing sustained good valve performance from the TAVR devices, too, with low rates of thrombosis or needing reintervention.
And this kind of data, it feeds into clinical practice, into guidelines.
Absolutely. The ACHAA guidelines from 2020 already opened the door for TAVR in certain lower risk groups. This 5-year data just provides more robust, longer-term evidence supporting that.
But it's not the end of the story, right? There's longer follow-up planned.
Definitely. They're following these patients out to 10 years. That data will be critical, especially for looking at the really long-term durability differences between TAVR and surgical valves.
Then your data will be fascinating.
It will. And the authors rightly point out limitations. Some patients lost to follow-up, echo measurements only at certain times.
And technology keeps moving forward, too.
Exactly. Both TAVR devices and surgical techniques have evolved even since these patients were enrolled. So today's procedures might yield slightly different results again.
Good points. Okay, so for you listening in, the key takeaway from our deep dive today, these 5-year Evolut Low Risk results strongly suggest TAVR is a durable alternative to surgery for low-risk severe aortic stenosis patients.
Comparable death and disabling stroke rates, similar high quality of life.
But it's crucial, as we discussed, to remember those nuances.
Absolutely. While the primary outcome was similar, think about those secondary endpoints. Higher AFib risk with surgery.
But significantly higher pacemaker risk with TAVR.
Right. And that potential small signal towards more MIs with TAVR. These are things clinicians and patients really need to weigh up for individual decisions.
Definitely part of that shared decision-making conversation. If you want all the intricate details, we absolutely recommend checking out the full paper in JCC. There's way more in there.
For sure. Valuable reading for anyone treating aortic stenosis.
So let's end with a thought for you to mull over. We've seen 5-year data showing TAVR holds its own against surgery in low-risk patients. Technology in both fields is advancing rapidly.
Constantly improving.
So, thinking ahead maybe 10 years down the line, what do you think the landscape for treating aortic stenosis will actually look like? How might these choices evolve further?
It's a fascinating question. Will TAVR durability hold up? Will surgical techniques minimize invasiveness further? It's a dynamic field.
Something to keep watching. Thanks for joining us.